The title of today's presentation is Necessity and Urgency of Developing a New Drug for Isolated Systolic Hypertension. Isolated Systolic Hypertension, called ISH for short. Have you ever heard of ISH? Many people have heard of prehypertension and first stage hypertension, second stage hypertension. But I think you are unfamiliar with isolated systolic hypertension. However, isolated systolic hypertension is one of the categories of hypertension, as you can see in the table, which is high systolic blood pressure but low diastolic blood pressure. In general, hypertension is high in both systolic and diastolic blood pressure, but isolated systolic hypertension is unusually high in systolic blood pressure and rather low diastolic blood pressure. More precisely, when systolic blood pressure is above 140 and diastolic blood pressure is below 90, it is classified as isolated systolic hypertension. The pathological reason for ISH is largely found in stiffness of aorta. As you get older, the stiffness of aorta progresses beyond the stiffness of peripheral artery, and the pulse wave velocity increases. This causes reflected wave, which usually return during diastolic period, return quickly and occur in systolic period. This causes an increase in systolic blood pressure and a decrease in diastolic blood pressure. Regardless of gender and race, systolic blood pressure rises as age increases, but diastolic blood pressure falls as age increases. To say that blood pressure rises as you get older is half right and half wrong, because systolic blood pressure continues to rise, but diastolic blood pressure decreases after 50s. This makes isolated systolic hypertension the most common form of hypertension in older people. In other words, ISH is not a common classification that we've heard of, but it is most common form of hypertension. As everyone knows, a continuous increases in systolic blood pressure cause stroke, hypertrophy, heart failure, and decreases in diastolic blood pressure causes ischemic heart disease such as coronary heart perfusion. High systolic blood pressure is not only a problem, but lower diastolic blood pressure is also the subject of treatment. I brought an example of ISH. It's an example that we often encounter in the clinical field. As you can see, systolic blood pressure is quite high in 3 patients, but diastolic blood pressure is below the normal range. ISH is also one of the categories of hypertension, so treatment to lower blood pressure is needed. At this time, guidelines for hypertension treatment by European Society of Hypertension are very helpful. This is because the guidelines suggest not only a drop in systolic blood pressure when treating hypertension, but also lower limit of diastolic blood pressure. European Society of Hypertension recommends that diastolic blood pressure should not fall below 70 when treating hypertension patients. This is what we understand as a Jacob phenomenon. The constant drop in blood pressure leads to an increase in mortality. As you can see in this table, you can see a significant increase in mortality curves, especially when diastolic blood pressure falls below 70. As mentioned earlier, diastolic blood pressure is an indicator of coronary perfusion, and it can be assumed that excessive diastolic blood pressure drop may have caused ischemia, such as coronary artery. Same treatment guideline for hypertension patients can be also found in the Korean Society of Hypertension. When treating hypertension in elderly patients, systolic blood pressure should be adjusted to less than 140, but diastolic blood pressure should not be lowered to less than 70. This is because if the diastolic blood pressure decreases below 70, the risk of mortality and coronary artery disease may increase. Here is a summary of the effect of blood pressure drugs that are now widely used. Calcium channel blockers have been reported to lower systolic blood pressure by 15 and diastolic blood pressure by 10. Similarly, ACE inhibitors and diuretics have been reported to have a similar degree of lowering effect. These antihypertensive drugs have in common that they lower systolic and diastolic blood pressure at the same time. Therefore, these antihypertensive drugs are quite effective in patients with stage 1 or stage 2 hypertension because their systolic blood pressure and diastolic blood pressure are elevated at the same time. However, the hypertension drugs currently in use are not optimized prescription for patients with ISH. This is because ISH patients already have very low diastolic blood pressure. So if they continue to administer blood pressure drugs to lower high systolic blood pressure, diastolic blood pressure will be lower too. ISH patients are a form of blood pressure that we often encounter in the clinical field, but they are in dilemma situation to approach only with conventional blood pressure drug. I would like to introduce you US statistics on ISH. According to US Health and Nutrition Survey about 200 million people, about 59% of hypertension patients undergoing treatment but with uncontrolled blood pressure were ISHA patients. In particular, most of patients in 60 and older who were not controlled by blood pressure drugs were ISHA patients. Let me explain the above survey in more detail. ISH is the most common form in hypertension patients in 50s and older. 3/4 of hypertension patients in 70 and older were ISHA patients. Their mean blood pressure was systolic blood pressure 154 and diastolic blood pressure was 73. 1/3 of all ISHA patients already had diastolic blood pressure below 70, and 4 million ISHA patients had diastolic blood pressure below 60. As you can see in the title of the paper, isolated systolic hypertension is called unsolved problem. We are using a prescription called BCD-101 to these ISHA patients in the clinical field. BCD-101 is modified Sengmexan, which is a traditional herbal treatment for circulatory diseases. Now we use BCD-101 to lower systolic blood pressure more selectively while maintaining diastolic blood pressure in ISHA patients. I am currently involved in two government R&D projects to develop BCD-101 as a blood pressure drug, especially ISH. I'd like to briefly introduce the two R&D contents. First of all, we are ongoing research with NICOM and KIOM. We are currently preparing several data with the aim of entering phase 2 clinical trials next year. NICOM is in charge of producing trial drugs and placebo for clinical trials and preparing CMC data. KIOM is in charge of strategy establishment such as clinical trial protocols and overall development management. Gyeongin University and Wongang University Hospital have been recruited as sites for phase 2 clinical trials. Next, as the original technology holder of BCD-101, we are preparing research and materials necessary for submitting IND. We are preparing standard analytical methods with Professor Hyun Kim, and we are conducting research on mechanism of action with Professor Jin Bong Park. In addition, research on the development of formulation and manufacturing process to be used in clinical trials is also underway with Professor Sung-Kyu Jin. The formulation of the test drug to be used in clinical trials is being prepared in the form of soft extract. And for this purpose, cooperation with BGMP is underway to supply raw drugs that meet quality standards and extract high concentration of ethanol. The finished test drug and placebo will be carried out at the Herbal Medicine Production Center, and a 36-month stability test will be conducted with the preparation of CMC data necessary for IND submission. Along with successful phase 2 clinical trials, the application for phase 3 IND is a priority milestone, and ultimately aim is to develop effective and safe treatment for isolated systolic hypertension. For this successful end, we will do our best with great researchers such as NICOM and KIOM. Now back to isolated systolic hypertension, ISH. The goal of my presentation today was to say that diastolic blood pressure should not be lower than 70 during treatment for ISHA patients. And the development of ISHA drug is necessary and urgency. Thank you very much for listening today.